So thank you very much. It's absolutely wonderful to be here today, and thank you so much to the organisers for inviting me. I've been told that we've got a bit more time than I've been allotted, but I realise I'm the speaker that's standing between you and lunch, so I will keep my pace up. Okay, so this is where I start off with a really sad declaration. This is like Billy No Mates. I've got no large sums of bribery from pharma or anything, but I did want to mention that I had a very pretty silver jug from the Danish Stroke Association last year. But in terms of anything else, nothing, even the jug, is affecting my presentation today. Okay, so the term fatigue. This is a term that people didn't really used to use, but really over the last 10 years or so, and certainly since COVID, it's a term that's become much more common in society. And that's a problem for people who have clinical fatigue, because whereas they see other people who are using the word fatigue when they mean they're really tired, they can't push through. So, for example, when they compare themselves to other people are saying, oh, I've got really bad fatigue, but actually, no, I can just probably do another 10 minutes work. People that have fatigue often hit a wall and they can do nothing more. But if they're compared against other people, then they look as if they really just haven't got enough will to push through. So what is post-stroke fatigue? Well, I'm very fortunate because the answer is in this paper that was published last year. This is one of the round table papers, and it's setting out definitions of fatigue and the way forward, and you can access that online. But just to save you some time, this is the definition moving forward that we're asking people in this area doing research and working clinically to adhere to. And as you can see, it covers not just physical fatigue, but it covers psychological fatigue, it covers cognitive function. It is a bit syrupy. So what do I usually say to my patients? I usually say this. I say, so what is fatigue? It's something that's chronic. It's not a short-term thing. And people, if they don't use the word fatigue, they will use terms like, I'm exhausted, I'm wiped out, very emotive language. It's unrelated to previous activity. If they just run a marathon, you might expect they would say they were fatigued, but most of these people are talking about getting up in the morning, getting washed and dressed, and then they are done for a couple of hours. It's often unpredictable, although some people can talk about triggers, but we'll come on to that, but not everybody does. And it doesn't be resolved by having a rest or a sleep. So what's all the fuss about? Well, the fuss really is that it is one of the most distressing symptoms that people have after their stroke. Now, I'm quoting a really old reference here because if we would just listen to what people are telling us, we've known for a long time. We think as therapists, so we think as medics, the problems with stroke are around, for example, they can't walk or they've got a problem with their arm. But they're telling us that one of the most distressing symptoms they have, and they've been telling this for a long time, is their fatigue. And it affects a lot of people. Again, I'm putting up an old reference because we should have known this for longer. This was a survey that Chris McKevitt did. He did this in 2011, and everyone was really surprised, particularly around the findings of fatigue. And the other reason why there's a fuss is that it's a priority. It was, if you think about it, like the top 10. It wasn't the top 10 in the previous round, but now it's moved up to position number 4. And I think this priority is really funny because I think what it's saying is, tell us anything. Tell us anything about fatigue. Tell us something about the numbers, how it affects people, what we can do, because we really know very little. And so often when you go and you hear someone talk, they'll say there was no previous research in this area and that's why we did the work that we're doing. Well, honestly, there are libraries and so many documents about fatigue. The difficulty trying to sort it out is it depends what lens people have applied in looking at that fatigue. So some people have come at it much more from the point of lab-based work. They're looking at biomarkers and they're looking at bloods. Other papers are looking at psychometric testing and whether people have different sort of types of personalities. We're looking at it from the point of view of brain scans. We're looking at it from the point of view of different types of interventions. So there's a lot of research out there, but it's not telling us what we really need to know. And of course, there are some really wacky things out in society that tell us that this is a cure for fatigue or this is a way forward. So let me save you some time here. If you want to do a project on fatigue, these are the references that you really need to look at. You need to look at professional guidelines such as NICE or at the RCP guidelines. The problem is that they haven't got much evidence to go on, so they rely very much on consensus and recommendations. And the problem with that is that until very recently, they haven't asked people who probably are the real experts, the people who have fatigue. But in the last round, that has resolved, and in the last panels of clinical guidelines, we've had a lot of stroke survivors and carers involved. Probably the most famous paper is the paper by Hinkle, and that's been updated by one of our students. We've got some prevalence data from a European study, and we've got the round table position paper. The problem is all of these papers, all of the Cochrane systematic reviews and everything that have been done, the word is promise. Do you remember at school when they said you have promise? It's kind of like you might be there, but you're not quite there. So this is what all the interventions that we have looked at, this is the results. They might be useful, but then again, they might not. So what are the facts? Okay, we're going to have some audience participation time now. I'm going to ask you some questions and you're going to have to decide whether it's true or false. This is a bit of fun. Please don't be looking round. Don't get really paranoid about it. Don't try and have a score. It is really just to test your knowledge and to keep you awake before lunch, because this is the slump time in everybody's conference. Okay, so the incidence of fatigue after stroke is approximately 50%. If you think it's true, put your hands up. If you think it's much lower or it's much higher, then keep your hand down. So who thinks 50%? Okay, so you're right. So there is some disagreement about the numbers. In some papers, it's as low as 25. In some, it's about 75. The problem is how you define it and when you measure it. But generally, most authorities now accept it's about 50%, which is still a huge number. So if you said that, you're right. But the thing to remember is fatigue is not static. You don't either have it or you don't have it. So in this study by one of our PhD students, we found that people started off with fatigue, and for some people it resolved, whereas some people find that they didn't have fatigue, but it started at 6 months. So it's a very fluctuating pattern, and you can't think you've got fatigue or you haven't. Fatigue is linked to increased mortality. That sounds a bit of a statement. Do you think that people having fatigue are more likely, basically, to die earlier? If you think it's true, put your hands up. You've been primed. Okay, so it is true, but it's not a direct relationship. So the issue is not you've got fatigue, you're going to die. The issue is that because you've got profound fatigue, you are less likely to get involved in your rehabilitation. And because you cannot participate in your rehabilitation, you're not going to get your best functional outcome. And because of all that, it is increased for mortality. So this is something that is quite important. And again, some of these references are quite old, and we have taken our eye off that ball. So that was right. Taking statins is linked to post-stroke fatigue. Do you think that's true? Put your hand up if you think it's true, and keep your hand down if you think it's false. So only one person thinks. Right, okay, let's see. Well done on being so brave, sir. I always like someone who swims against the tide. Okay, so the results of research that we've had so far suggest that it's not any particular medications, it is the sum of the medications, which we actually know from studies of falls and in other areas. And this is a study done by a French group. So they found that having fatigue was much more related to the number of medications that people were on. But there are many people, particularly stroke survivors, who believe their statins are responsible. So what I'd say to them is, for heaven's sake, don't stop taking your statins. But I know, for example, Professor Gillian Mead in Edinburgh will have a conversation to see if she can try and reduce people's statins if they really believe this is the issue. But there is no evidence. Having said that, if you look at most medication packets, it probably says extreme tiredness on them all. So I don't know how that helps us at all. Okay, there's a direct link between depression and fatigue. Do you think that's true? If you do, put your hand up. Well, that's overwhelming. And of course, there obviously is. But it's a bit of a chicken and egg. We know that people who are depressed often have symptoms of fatigue. And we also know that people who are fatigued often go on to have very low mood and depression. So there is that link. But one of the balls that we have dropped as well is that there is this issue about anxiety, and this has come through on a couple of recently published studies. Anxiety seems to be quite an important aspect of people developing fatigue. So the bottom line is, yes, depression is important, low mood is important, and you don't want to miss that clinically. But also anxiety may be quite an important key in this area as well. Fatigue is likely to resolve within the first year post-stroke. If you think that's true, put your hand up. Do you think it resolves after a year? Okay, not very many people. That's not true. And that's on anecdotal evidence as well as the scientific evidence. And again, I'm putting up a systematic review published in 2012 that told us that. And all the most recent publications particularly in some of the Scandinavian countries, suggest it may last for 7-8 years. And that's really quite a long time. So that's not true. And finally, post-stroke fatigue is different to fatigue reported in other conditions. If you think that's true, put your hands up. So I'm sorry, I'm being really mean. It's a trick question. We don't really know because we don't have the fatigue, so we don't know. What we can say is from the literature, there seems to be quite a lot of overlaps with fatigue that people have if they've got MS, Parkinson's, rheumatoid arthritis and cancer, and less so with long COVID and chronic fatigue syndrome. And so you're kind of right and you're kind of wrong. But one thing I would say to you, and this is not the focus of my talk today, that all fatigues are not equal. You probably know there's quite a lot of controversy with the last NICE guidelines around the treatment of chronic fatigue syndrome. And you have to be careful in treating people with that in terms of exercise and what you're doing, because this group of people very clearly have muscle changes, which is different from what we see in neurological fatigue. So the big question is, so what? That's the reality check. So the facts are a bit depressing, but so what? Well, we really wanted to try and find out what the implications of fatigue were for people with fatigue. And we did 2 studies. We did one study where we assessed people on a fatigue scale. We made sure that they were about 6 months after their stroke and they were in a catchment area, so we interviewed them in person. And we did another study where we just kind of opened the floodgates during COVID. We said, do you think you've got it? If you have, you're in. Any time point and any location. We did it online, so we included people with aphasia. And really, we just put the results together because there were no differences between the people who self-identified and the people that we found. And the sorts of things they said, these are some of the quotations up there, but these are some of the things about how it had really affected them. And particularly shopping. Many people mentioned shopping, about having a shopping list, going into the shop, the lights, the music, the people, and this whole new mood that we have where, just when you know where the milk is, they move it to make you go and find it somewhere else and maybe buy a loaf of bread on the way. That absolutely, completely uninches people who've got fatigue because they just often walk out without doing their shopping. So a lot of things that you take for granted that you do, people can't do. And when we asked them about who's talked to you about fatigue, the big thing was that very few people had mentioned it. Now, some of the patients absolutely recognised that if they went to see their consultant and their blood pressure was high, that's going to be the focus. But it was in the wider teams that no one had even spoke to them about it. So they really didn't understand what was going on. And again, this emphasis not just on physical fatigue, but that they felt that they really couldn't think straight and they couldn't sort things out. Just as an aside to that, we've had a PhD student look at this, and what we can say is that we are pretty confident that people still make good decisions, it just takes them longer. So there's no indication that the fatigue makes them make bad decisions, it just takes them longer to process what they want to do. But this is the best thing that anyone has ever said to me about fatigue. I'm just going to give you a second to look at it. But I often think if I've had a hard day, I don't know what you do, I watch trashy TV. I'm the trashy TV queen. So I watch all these programs that my husband said I should be embarrassed, and if anybody knew, wouldn't I honestly probably go to hell or something. But things like Say Yes to the Dress or Married at First Sight, honestly, because I don't have to concentrate, I don't have to think about it. I read the same couple of pages every night when I'm really tired because I can't remember the night before. But these are things I do to kind of de-stress and manage. But what our patients are saying is that they have no reserve to even do that. They often have to have a rest in a completely dark room with no noise, no stimulation at all, which really feeds to some of the theories about sensory overload. And again, let's not forget the effect on carers, because we have carers, their life has changed enormously. And they sometimes have to act, someone said to me, Mr. Policeman, because if my husband doesn't realise that he's doing too much, we're really going to pay for it the next day, both of us. So they have this kind of policing of the person with fatigue to make sure that they don't do too much. So what's all the fuss about? So the fuss is that this is a really big problem, and we don't seem to be getting any traction on managing it, and we probably haven't taken it as seriously as we should have done. So this is one of the reasons why we did what we call the NotFast2 study, the Nottingham Fatigue After Stroke study. We basically tried to find out what are the therapists doing around this area, what do they think, and what do the people think we should be doing to help them, and then these co-design groups, which were a real highlight of our study. So we did a survey. We did it during COVID. We were quite happy that we got over 300 people. And the sorts of things that people were saying to us was that they managed it by pacing, which means getting people to have rest periods on one day or heavier days during the week than others. Keeping a diary they recommend people to do, although that's a bit vague because they didn't really say what they should be doing in keeping the diary, what they should be recording, or if anybody even reviewed it. So somebody could be keeping a diary for weeks, who's going to look at it? And education around the patient and around their carers. But there were lots of others, and some were frankly stranger than others. We also did the survey in Australia with Australian therapists, and we got the same results. But what we find in the UK in managing fatigue, and particularly post-stroke fatigue, was that there are huge variations. Really, we've heard about that already across a number of conditions, and in terms of the follow-up. So in some cases, you could be on someone's books for 18 months, and in other areas, you'd get one visit. There was very little assessment. And I put a sigh in here, and in some cases, the clinicians developed their own tools, which is frankly, yeah, that's just a sigh. When somebody else has done the work for you, why would you develop it on the back of a fag packet? Clinician interviews. We wanted to get 20 interviews. We wanted to include people with post-stroke fatigue, but people with other conditions. I'm not going to go into all the details, but we used maximum variations. So we had older and younger people, people in work, people not in work, people who had a severe stroke, people who had aphasia, different ethnic groups. And we analysed it. And we were quite fortunate that we got our sample and we got some people outside the UK just to compare if people were doing anything different in other countries. And they all actually, it was like somebody told them the answer. They all said the same sorts of things. They said it whether they were different professional groups. They said it whether they lived in Scotland, Northern Ireland, England, or in Australia. The OTs really felt this was their area, but other people felt ownership of it. But the really big thing is that they all relied on personal knowledge, no sort of clinical background or education or training. They just kind of did it on what they thought. And we asked the clinicians about their thoughts in other areas, and the things that came through was the fact that they really felt people had to accept it, that they couldn't push through it, hence the pacing, that they really felt that it was important to take an interest in because then it validated the person's experiences, that they felt really educating the family because they often saw families saying to someone, you've got to do more, you've really, really got to do more, and using the term lazy. And again, the problem that they identified was that there was no evidence base for anything that they were doing. So then we asked probably the real experts, the people with fatigue. And we interviewed 20 stroke survivors and their carers. And we had quite long interviews with these people, and we didn't give them a break because remember, they had got fatigue. And all of them talked about it in a negative way. Now, most times when you interview people, somebody comes up with some spin where they say something positive. Nobody said anything remotely positive about having fatigue. And they talked about the fact that they'd realised time and time again when they pushed against it, they couldn't get past this wall and they had to accept it. Some people found pacing was useful. Some find diary useful, but I remember one guy saying to me, I get exhausted doing my diary. It actually is the thing that wipes me out. So you think maybe somebody should be telling them not to keep a diary. We talked about educating family. People find that really important because they genuinely didn't know. Coming through COVID, people are more aware, but still not as aware as we'd like them to be. And they found professional advice when it was helpful, really helpful. But again, most people developed their strategies themselves. They didn't have anyone advising them on what they should be doing. And finally, we did some co-design groups. Now, we've actually had quite a lot about PPI involvement. I just want to put out there, this is really hard work, particularly when you've got people with fatigue. When you're trying to get people with fatigue, and in our case, it was at the end of COVID, we had to do a lot of groups outside the groups to educate people on using Teams and how to manage. We had people who got up and with the best will in the world were just so wiped out they couldn't participate. And we had professionals who'd been called away. It was frankly, running these groups was like herding cats. I mean, honestly, I'm just going to put it out there. When I write the paper, probably not going to say that, but I'm telling you, PPI is wonderful, but it's really, really hard work. And again, we had people with aphasia, including them is really important, but that's a whole skill set and a lot of work behind even running the groups. But we had 35 people, we held 5 meetings. Again, we had a lot of breaks for people before anybody's thinking that. And actually, quite interesting, some of the professionals who volunteered to do this, they actually disclosed in the groups that they also had fatigue. And we just thought that was quite interesting to find. So the key points that came from it was they found that healthcare professionals often really annoyed them, because they used words like very tired. And they also used words like, normal when you were normal, or again, terms that they just thought were quite pejorative. When they did find a health professional who knew what they were talking about, then they found that really useful. And again, they emphasised more and more, a bit like your bank account. If you spend the money in it, it's very difficult to go into overdraft, but that's what you're really doing. And sometimes you're not going to get the overdraft because you're spent up. And that's the way people described having their fatigue. So what on earth do we do? Well, we've heard this already from a previous speaker. I'll have to talk afterwards. We've obviously got a big kind of Irish component here today. So one of the things that were really important is that people said nobody talked to them. They talked about their arm, might have talked about their vision, maybe not. They might have talked about spasticity, about their walking, their continence, but nobody mentioned fatigue. And people often felt that this was something very different happening to them that other people didn't have. And even just acknowledging that this exists, even if you can't say this is the answer, was really, really important. Moving forward in the roundtable paper, we're trying to encourage people to do some assessment. Now, this is a really confusing area. We talk about the fatigue severity scale, but who knew it's the same as the fatigue assessment inventory instrument, which is a subsection of something else. So people get really confused about what scales, but the scale we're telling you to use is the fatigue severity subscale, and it's a very simple scale that you can hand people to do, and they really just look at a series of comments and they score it from 1 to 7. And there are quite a lot of work done by Anders Lardal and his team in Norway looking at clinical cut-offs, but a cut-off about 36 suggests this really is impactful fatigue. And just to show you the scale, and I'm quite aware of time as well, so I will keep going, but just to show the scale here, these are quite simple questions where people are rating themselves. And I had an old professor who used to say to me, if you can't measure it, you can't manage it. So it is quite important so that people know where they are on a scale and that they can be monitored over time to see, is it getting worse? Is it getting better? It's just important for them. Finally, we're asking people to use this agreed definition. I mean, this is a consensus definition. You put all these people in a room and you come up probably this wouldn't be my definition, but this is the group definition. And this is what we're asking people to use, because moving forward, then we can be sure that people are all on the same page. Ongoing research. So we have had an increase in funding and an increase in this area, and there is more research out there. We are doing, we couldn't think of a more original name than NotFast 3. I'm hoping we don't go to a NotFast Mark 4, but we're about to start a trial of the intervention we developed in our co-design groups, and we're going to start that in a feasibility study very soon. Again, our Australian colleagues are looking around a fatiguometer, which is again about looking at measuring fatigue, because although we've recommended a measure, we recognise it has some limitations, and certainly there is some more work going on around that. It's important to think about drug trials. There is some promise in modafinil. There is an Australian trial going on. I think there are some centres in the UK. Some interest in cortical excitability, that's coming through the UCL labs, and again, some promise in some of the results. And again, there are particular interventions, so there is some promise in exercise, which sounds counterintuitive, but that really links into some of the MS research that's been done about the value of exercise. So there is ongoing research in this space. So finally, what is all the fuss about in this area? Well, the fuss is, this is really common. If we're saying 50% of people who have a stroke have fatigue, that's common. It's significant. This is not a trivial thing. This prevents people engaging in rehab, and it prevents them even engaging in life, even when they've otherwise made a very good functional recovery. Our evidence base, frankly, is dreadful. I mean, I'll say weak because that's a scientific term, but when you consider how much time and energy has been spent, we've got very little to show for it. Our stroke survivors and their carers want to talk about it, and even if we haven't got an answer, talking about it is really important. Assessment is also important, and we should take that seriously, particularly for people who we think have significant fatigue. And finally, we absolutely have to do better and more targeted research. Thank you very much for your time today. Thank you.
Really well to keep it on top.
I just left a bit out in the middle. It's fine.
Do we have any questions from anyone? Let's get the mic over.
While I'm walking, I will just say I am not sure if you call it Xing or if that's really illegal or if it's tweeting still, but we often put results from our studies out under my account, so I will just say that while we're getting the mic to somebody.
You want to go first, Peter? You want me to go? Really good talk. Probably one of the most devastating effects of stroke that I've seen in the last 21, 22 years. I tend to tell all my patients what to expect, even though they may not get it. So I'm not saying you're going to get it, but don't be surprised. I think acknowledging it and allowing the family to know about it, it really helps them cope with it, because you get a lot of families going, he's not doing enough, he's being lazy, and causes a lot of conflict and upset. So the understanding helps. We don't like talking about it because we don't know what to do about it, and I think that's part of the reason people avoid measuring it, and because you measure it and then do what with it.
Yeah.
I've dabbled with Reiki. I've done Reiki and complementary therapies and things like that, and I've always been interested in the Chinese model of chakras and energies and all of that malarkey. And I just wonder whether we in Western medicine, we look at the human body in a certain way, and we don't acknowledge that different model of looking at humans, which is actually we're energetic beings. There's energy flowing through us, going through from the ground upwards and around us, and it is a thing, I believe, from my experience. And I always wondered whether suffering a cerebral insult could affect the flow of energy, and hence your energy flow is blocked. And actually, the problem with us is we're not looking at it from that aspect. And I have always thought it would be really interesting to kind of look at various complementary therapies such as acupuncture, reflexology, Reiki, for another example, is to say, actually, is that a way of addressing this fatigue? Is it going to help? Is it not going to help? And sometimes just going down that avenue of giving yourself time, giving yourself a therapy like that, allows you to open up about your emotional and psychological state, which is all interlinked with the fatigue. And I just think it would be really interesting, but unfortunately there's no money to be made in drugs. Pharmaceutical companies will support research, and usually with complementary therapy you just don't have the time, the practitioners, and the resources to do it. But I've always wondered whether you've ever had any experience of patients trying complementary therapies and whether it's had a beneficial effect on it?
Okay. So this is absolutely a personal opinion, and I cannot actually demonstrate this in a scientific way. But I often find that if people really believe in something, if they feel, the thing about fatigue, I think, is, and again, this is an opinion, is that people have lost control. They've got something happening to them and they can't control it. And so some people will swear by X, some people by Y, whatever. It almost doesn't really matter what it is as long as it's not harmful, if they feel that they can self-manage within that. Now, interesting, I've actually got an honorary post with Hong Kong University, and I'm quite aware that they've done some work around acupuncture with fatigue. And again, that nasty word, promise, comes up. Again, for some patients, it does seem to be beneficial, but others it hasn't made a difference. Other complementary therapies, again, we have talked to people who've relied on different things, you know, kind of smelly oils and all the rest of it. And again, I'm really not dissing it, because I think if people feel that that is really helpful to them, then it's helpful to them, and we don't actually have much better to offer them at the moment.
Thank you for talking. It was very interesting. There are lots of other conditions where you get fatigue. I mean, COVID's what's most known now, but myocardial infarction, for example. And I was just wondering how much support services for fatigue need to be specific to stroke, or whether we ought to be designing services for fatigue regardless of the condition that has prompted it.
So that's an excellent question, and that's a very pragmatic question. Now, obviously, in terms of our research funding, we're going to get a stronger bid if we actually ring-fence a particular condition. I am aware there have been some studies that have looked at more generally in fatigue, and bluntly, I think that they have come unstuck because, again, the portfolio is so wide, and they have found some anomalies that's been very difficult. So I think if we could crack this nut around post-stroke fatigue, we probably could extend it more widely. Certainly there's been some really good work with exercise in MS. There's been some promise in stroke with exercise. So there is potential to really put this out pragmatically. But the problem is we can't really design a great service, because unless it's going to be talking to people, we're not able to offer them anything that we know will absolutely work. Oh no, this is going to be a nasty question.
Oh yeah, that's it. So I'm inviting a reframe of this. You said promise is a dirty word, but if we acknowledge that no two strokes are the same, everyone's individual, what they believe in might work for them, isn't promise sufficient to then have a buffet of things? You said these things have promise. What one appeals to you? Should we try them? I think promise seems like a good thing, rather than the idea of having definitively knowing, well, this is you standing in front of me in a 10-minute assessment I can do, this will work for you. Ultimately, what might work for someone is completely a factor of like their beliefs, their support network, so much more than we can maybe get a grip on in a brief assessment. I don't know. Why do we think promise is a dirty word?
So I suppose
maybe that's my question.
I think it's because I'm frustrated that, given all the work, all the research, all the money that's been spent in this area, that we still don't have anything that's stronger than a pulse. And in some places it's a pretty thready pulse. You know, I absolutely accept that people might find different things that suit them. But this is a big problem, and whether it's a drug intervention, and I'm coming at this from the point of view as a frustrated occupational therapist with lots of patients with nothing I can really do for them. But I absolutely accept people are coming at different angles, and that's great, because maybe there'll be a sweet spot in the middle where we can actually manage people in terms of whether it's a drug or whether it's in terms of identifying people on a brain scan. But my frustration is that after all this time and many trials, that we haven't got anything that is more promising than just a promise. So I take the point, but...
Okay. Thank you
Thank you so much.
Avril.
Thank you.